Hi everybody, welcome to my YouTube channel Dr.Sreenivas Medical Concepts and my FB page Dr.Sreenivas Concepts. This is Dr. Sreenivas, neurologist from Andhra Pradesh, India. I'm also the medical author of the book Focused Neurology. Today we are going to talk about a very important and common topic, epilepsy. Seizures, fits and epilepsy. The most important points, the indispensable concepts of epilepsy. Here we go. Seizure. But before we go to the actual topic, we need to understand few definitions. Seizure, epilepsy and epilepsy syndrome. What is seizure? Seizure is a transient occurrence of signs and symptoms due to abnormal, excessive or hypersynchronous neuronal activity in the brain. So seizure is a transient occurrence of the signs and symptoms due to abnormal, excessive and hypersynchronization of neuronal activity in the brain. So seizures could be sensory, motor or psychogenic. Epilepsy. Epilepsy describes a condition in which a person has a risk of recurrent seizures due to chronic underlying process. Recurrent seizures, but then the recurrence should not be due to correctable or avoidable factors like hypoglycemia. So epilepsy is a condition due to a chronic underlying process in which a person has got a recurrence of seizures, but the recurrence should not be due to correctable or avoidable factors like hypoglycemia. So if a person has got a tendency for hypoglycemia and has got recurrent seizures, that does not qualify as epilepsy because it's an avoidable and a treatable conditions. So avoidable, treatable or provoking factors are not considered for the diagnosis of epilepsy. So what do we understand by this? Epilepsy is because of two or more unprovoked seizures. Two or more unprovoked seizures. That means it should not be provoked. It should not be due to correctable or avoidable factors. And then finally we have epilepsy syndrome. Epilepsy syndrome is a syndrome in which the clinical and the pathological characteristics are distinctive. The clinical and pathological characteristics are distinctive and it suggests a specific underlying etiology. Example, Measle temporal lobe sclerosis, Lennox Gestart syndrome, juvenile myoclonic epilepsy. These are the clinical syndromes. They have clinical and pathological characteristics which are distinctive and they suggest a specific underlying etiology. So we need to understand these three definitions, very important, before we actually take on the actual epilepsy concepts. So seizure is a transient increase or occurrence of signs and symptoms due to abnormal, excessive or hypersynchronization of neuronal activity in the brain. So it could be motor, it could be sensory, or there could be an autonomic impairment, cognitive disturbance, dyscognitive states, where we say there is an impaired awareness also. Epilepsy is a condition where there are recurrent seizures due to an underlying disorder, but the recurrence should not be because of a correctable or avoidable factors. So by this, the definition of epilepsy is two or more unprovoked seizures. And finally, we have epilepsy syndrome, which is a syndrome where there are definitive clinical and pathological characteristics which are distinctive, and they suggest a specific underlying etiology. Example, juvenile myoclonic epilepsy, Lennox Gestart syndrome, or Measle temporal lobe sclerosis. Fine. How do we classify seizures? Basic approach, when we approach a person with seizures, we need to classify. Basically, the best way to approach a person with seizure is to find out whether it's a focal seizure or a generalized seizure. Like in headache, how we approach whether it's a primary headache or a secondary headache. Primary headache is that headache where there are no definitive causes. The disorder itself is a diagnosis, primary headache. Whereas secondary headache, they are because of exogenous causes. Likewise, seizures, when we approach as a focal seizure where the seizure focus is confined to one cerebral cortex, or generalized where they emerge or they involve both the cerebral hemispheres. So the best way to approach seizures is whether it's a focal seizure or a generalized seizure. So the fundamental principle, the fundamental and the basic principle is that the seizures may be divided into focal and generalized. So this is according to the 2017 classification, where we divide it into focal seizures, generalized seizures, and unclassified or unknown seizures. Right. Now let's talk about these focal and generalized seizures. So the primary approach for seizures is whether it is a focal seizure or a generalized seizure. Why is it important? The treatment is different, the causes are also different. So the focal seizures, they originate within the networks limited to one brain's hemisphere. So they originate from networks within one cerebral hemisphere. Whereas generalized seizures, they engage networks distributed across both the cerebral hemispheres. Focal seizures, they are generally associated with structural abnormalities of the brain. So it could be a tumor, it could be abscess, or it could be any structural cause or infarct. So they are, or temporal lobe involvement where there is a neurodevelopmental disorders. It could be some structural focal cause. So they are usually associated with structural abnormalities of the brain. So focal seizures are usually associated with structural abnormalities of the brain. Whereas generalized seizures, they result from cellular, biochemical, or there may be structural abnormalities, but then they have more widespread distribution. As I said, the causes are different for focal seizures and for generalized seizures. The treatment is also different. For focal seizures, we generally give carbamazepine or oxcarbamazepine. They are the drugs of choice. So carbamazepine, oxcarbamazepine, phenytoin, can give levetiracetam or valproate. For generalized seizures, valproate is a very good drug, followed by levetiracetam, lamotrigine, and phenytoin. So levetiracetam can be given for both focal and generalized seizures, but the preferred drug for focal seizures is carbamazepine or oxcarbamazepine, and the preferred drug for generalized seizures is valproate. Valproate is preferred because it can control many types of seizures. It can control absence seizures, typical absence seizures, atypical absence seizures, myoclonic seizures, and atonic seizures. So when a person comes with seizures, the fundamental approach will be to divide or classify into focal seizures or a generalized seizures. Now let's dwell into the details of focal seizures. Focal seizures again can be classified as the focal seizures having an effect of awareness. Focal seizures, depending upon the nature of the onset, whether it is motor or non-motor, and focal seizures evolving into generalized seizures. So first is focal onset seizures are classified into three types. The first type is focal onset seizures classified on the basis of effect of awareness, whether they are aware or not, whether the awareness is intact or impaired. So impaired awareness, it could be like Measle temporal lobe syndromes where they can have impairment of awareness also. Then the nature of the onset, whether it is motor or non-motor. motor or non-motor. So motor, it could be tonic, it could be clonic, it could be myoclonic. Non-motor, it could be sensory like paresthesias, visual disturbances, autonomic like sweating or piloerection, or they can have abnormal odors like a burning of the rubber, etc. What are the three salient features of focal seizures with intact awareness? What are the three salient features of focal seizures with intact awareness? First is the Jacksonian march. For example, the hand area and the face area are having a disproportionate high representation in the brain. So if it involves the hand, it may start with the hand and then slowly start spreading upwards to involve the shoulder and simultaneously the face. So slow spread of the seizure events, we call that as the Jacksonian march. Spread of the seizure activity, we call that as the Jacksonian march. Second, Torch palsy. When there is a seizure, after seizure for few minutes to hours, they may have weakness of that particular area where the seizure was present. So this is known as Torch paralysis. Localized paralysis following seizures. It may be from minutes to hours. And third, they can have a continuous epileptiform discharges giving rise to a continuous epileptic activity, which we call as epilepsia partialis continua. So the three salient features of focal seizures with intact awareness are: one, the Jacksonian march; second is the Torch palsy; and the third is the epilepsia partialis continua. We need to understand one more important concept, aura, because it's seen in some of the patients. What is aura? Aura, they are subjective internal events. Aura are subjective internal events like fear, micropsia, particles becoming small, or macropsia, particles becoming big, or depersonalization. So they are all subjective internal events that are not directly observable by someone else. So aura are subjective internal events that are not observable by someone else. This is aura, like fear, depersonalization, micropsia and macropsia. Right. These are the three salient features of focal seizures with intact awareness. And there is one salient feature of persons having focal seizures with impaired awareness. And that salient feature is automatism. So persons having focal seizures with impaired awareness will have automatism. The start of the ictal phase is often a motionless stare. When a focal seizure with impaired awareness starts, they can have a motionless stare to start off with, which marks the onset of the period of the impaired awareness. So they'll have a motionless stare. This is accompanied by automatism. What is this automatism? Automatisms are involuntary. They are involuntary automatic behavior like chewing, lip smacking, picking articles, swallowing or running about, which are usually accompanied along with the motionless stare. So automatisms are involuntary. They are not voluntary. The person is not aware of it. So they are involuntary automatic behavior like chewing, lip smacking, swallowing, picking up things, running around. So this is the salient feature of focal seizure with impaired awareness, automatism. The three salient features of focal seizures with intact awareness are Jacksonian march, Torch palsy and epilepsia partialis continua. Right. This is all about the focal seizures. Now let's see about the generalized onset seizures. We've just seen focal onset seizures. Now we'll see the generalized onset seizures. In this category we have the typical absence seizures, atypical absence seizures, generalized tonic-clonic seizures, atonic seizures, myoclonic seizures, and finally the epileptic or infantile spasms. The first is the typical absence seizures. This is seen in children. So they are sudden with brief loss of consciousness without postural control. So they don't lose posture. They have a brief sudden loss of consciousness with a good posture. It is seen in about 15 to 20% of children in the age group of 4 to 10 years. The EEG is very characteristic in absence seizures. Generalized symmetrical 3 Hz spike per second is the EEG finding that start and end abruptly. This is the typical absence seizures and they respond very well to valproate or ethosuximide. Then we have atypical absence seizures. As the name suggests, it is not typical like absence seizures. So the EEG is not like 3 per second, it is less than 2.5 per second. It is because of the diffuse multifocal structural abnormalities. So these are known as atypical absence seizures. It is because of diffuse multifocal structural abnormalities. And then we have the generalized tonic-clonic seizures, which is easily picked up by bystanders and attenders. Generalized, all 4 limbs to start off with. Tonic, a muscle contraction followed by clonic relaxation. So initially when there is the generalized tonic-clonic seizures with loss of consciousness because it is generalized, a tonic phase, a muscle goes for severe spasm, which includes the diaphragmatic muscles, so they have the characteristic cry. The characteristic cry of mourning is because of the contraction of the tonic phase of the muscles. They can have the contraction of the jaw muscles, that's why they have tongue bite. Then they have the clonic phase, relaxation of the muscles. Initially, there is a sympathetic hyperactivity and that's why the pupils are dilated during the seizure phase, ictal phase, and there's an increase in blood pressure. But once the ictal phase gets slowly controlled, the parasympathetic activity increases. That's why they have voiding of the urine. So voiding of the urine, why does it occur in generalized tonic-clonic seizures? It is because of the parasympathetic activity which occurs in the later part. But the initial part, there's an increase in sympathetic activity, though they have dilatation of the pupil and hypertension. The EEG is a progressive increase of the amplitude and the frequency to finally become spike and wave pattern. And these generalized tonic-clonic seizures, they are usually due to metabolic impairments. It could be hypoglycemia or it could be any other metabolic impairment. So metabolic derangements or impairment are the usual causes for generalized tonic-clonic seizures. And then we have the atonic seizures. They are seen in epilepsy syndromes. They are not generally seen in an isolation. They are seen in epilepsy syndromes. They can have atonia and they can, if it is severe enough, they'll even fall onto the ground, or they can just bend, or if it is severe enough, they can fall onto the ground. Then we have myoclonic seizures, sudden and brief contraction of a part of the body or the whole body. It is usually seen in metabolic conditions. It is seen in structural abnormalities like storage disorders. It is seen in hypoxemic encephalopathy. Very characteristic in hypoxic encephalopathy, we see myoclonus and therefore we give sodium valproate or clonazepam. Then we have finally the infantile or epileptic spasms. It is because of the immaturity of the brain, and EEG shows hips arrhythmia. Right, so far we've spoken about the focal seizures and generalized seizures. Now let's talk about the epilepsy syndromes. Epilepsy with a common underlying mechanism is epilepsy syndrome. There are 3 important epilepsy syndromes. First is the juvenile myoclonic epilepsy, second is the Lennox Gestart syndrome, and third is the Measle temporal lobe epilepsy syndrome. First, let's talk about the juvenile myoclonic epilepsy. It is characteristically seen in early adolescent age. Characteristically seen in early adolescent age. It is usually seen in mornings. And therefore, morning generally, the classic history is that when they get up in the morning and then try to have coffee, they have myoclonus and they are not able to drink coffee well, the coffee spills over. This is one of the characteristic history which we get from the juvenile myoclonic epileptic patients. So morning myoclonic jerks. The treatment is lifelong treatment. Though it responds well to valproate or clonazepam, the treatment has to be lifelong with a good response to anti-epileptic therapy like valproate. This is about juvenile myoclonic epilepsy. The other epilepsy is the epilepsy syndrome, the Lennox Gestart syndrome. It is non-specific response of the brain to diffuse neuronal dysfunction. So the brain can get affected in many ways. So it is a non-specific response of the brain to diffuse brain insults. This is the Lennox Gestart syndrome. So it could be because of the developmental disorders or genetic disorders. They have a classic triad. Lennox Gestart syndrome, they have a classic triad. They have multiple seizure types, not one seizure type. They have multiple seizure types. They have impaired cognition, and they have the characteristic EEG findings. So you have the multiple seizure types, the characteristic EEG findings, and then the impaired cognitive function. So this is the triad of the Lennox Gestart syndrome. And our third important epilepsy syndrome is Measle temporal lobe epilepsy syndrome, MTLE. It is the most common syndrome. It is the most common syndrome associated with focal seizures and impairment of consciousness with distinctive clinical EEG and pathological findings. Example, hippocampal sclerosis. So Measle temporal lobe epilepsy syndrome is the most common syndrome of focal seizure with impaired consciousness with distinctive clinical EEG abnormalities and definitive pathological abnormalities like hippocampal sclerosis. It is refractory to anticonvulsant therapy. Measle temporal lobe epilepsy syndrome is refractory to anticonvulsant therapy, but it responds very well to surgical intervention. So one of the good surgical indications in epilepsy is Measle temporal lobe epilepsy syndrome. So summarizing all the different seizure types, the classification of seizures according to the 2017 article, we have focal seizures, generalized seizures, and seizures of unknown onset. Focal seizures may be with intact or impaired awareness. It could be of motor or non-motor onset. The focal seizures may evolve into bilateral tonic-clonic seizures. This generalized onset can be again classified into motor like tonic, clonic or tonic-clonic or myoclonic, or non-motor, example absence seizures. Then finally we have unknown onset, again it could be motor, non-motor or unclassified. Right. Having had a basic knowledge of the types of seizures, now let's see the causes of seizures. What are the causes of seizures? The factors of seizure causation. Basically there are three important factors. One is the endogenous factors. Second is the epileptogenic factors. Third is the precipitating factors. The endogenous factors, as the name suggests, they are endogenous, like family history of epilepsy, like complex febrile seizures. So this is an endogenous factor. The epileptogenic factors, they are exogenous, like it could be head injury, stroke or infections. So we have endogenous factors, we have epileptogenic factors, and finally we have precipitating factors, factors which precipitate seizure onset, like stress, lack of sleep or hormone changes. So these are the three important factors which gives rise to seizures. Endogenous factors like family history of epilepsy, any genetic abnormality, exogenous factors like head injury or infections, and precipitating factors like stress, a lack of sleep and hormonal changes. Now let's see seizures etiology according to the age. So if a young child comes, what are the possibilities for seizures? If an adult comes, what are the possibilities of seizures? The seizures are commonly seen in the two extremes of age, less than 1 year and more than 60 years. Because less than 1 year, most of the developmental abnormalities and genetic abnormalities are common, and more than 60 years, cerebrovascular accidents and degenerative conditions are common. So seizures are very common in the two extremes of the age, less than 1 year or more than 60 years. Now let's see seizure causes according to the age. So in the neonate, less than 1 month, neonate, hypoxic encephalopathy is very common. Hemorrhage, periventricular hemorrhage is very common. Metabolic like hypoglycemia, hyponatremia, hypocalcemia, especially pyridoxine deficiency, vitamin B6 deficiency are very common. Drugs, if the mother is taking alcohol, that can go and affect the neonate and produce neonatal seizures. It could be developmental abnormalities and genetic abnormalities. These are the common causes of seizures in infancy, in neonates, less than 1 month. In infancy, that is less than 1 year but more than 1 month, and children, early age group, that is less than 12 years. So more than 1 month, less than 12 years, what are the common causes? Here very important, very common is febrile seizures. In this age group, febrile seizures are very, very common. Temporal lobe epilepsy syndrome also is common in this age group. And then again we have developmental disorders and infections. But two important conditions we need to remember in the infancy and early childhood are febrile seizures and Measle temporal lobe epilepsy syndrome. Then we have adolescence, 12 to 18 years. Here very important condition we remember, as I already discussed, is the juvenile myoclonic epilepsy. Juvenile myoclonic epilepsy is the epilepsy of adolescent age group. So very common adolescent age, we should always think of juvenile myoclonic epilepsy. And autoimmune encephalitis is becoming common. Autoimmune encephalitis is nothing but autoantibodies, the antibodies produced against our own system. So here the antibodies are produced against the glutamate receptor, that is the excitatory substance, or potassium channels. So how do we diagnose this autoimmune encephalitis? So they have a frequent and rapidly spreading epileptic seizures, fast progression with psychiatric disturbances, with abnormal psychiatric manifestations. We always need to think of autoimmune encephalitis. And then trauma is also common in this age group, road traffic accidents. Then young adults, that is 18 to 13 years, this is the age where trauma is common, tumors may occur. In this age, they may indulge in alcoholic intoxication, they may take drugs like hallucinogens, and here also the autoimmune encephalitis is common. And then when we consider the old age groups, that is the more than 35 years, so once they start hitting 40s and 50s, cerebrovascular accident starts becoming common. In fact, more than 65 years of age, if a person throws seizures, 50% of the time it is because of a cerebrovascular accident. Then they can have tumors, degeneration, trauma, subdural hematoma. Here they may have trivial injury, but the veins may have ruptured and cause trivial injury, subdural hematoma, and they may present with dementia and seizures. So this is very common. So seizures according to the age group is very, very important. In neonate, the pyridoxine, B6 deficiency, hypoglycemia, hyponatremia, hypoxemia, hemorrhage are very common, genetic and developmental abnormalities. In infants and young children, always think of febrile seizures and Measle temporal lobe epilepsy syndrome. In adults, always think of juvenile myoclonic epilepsy and autoimmune disorders. Young adults, you think of autoimmune disorders, autoimmune encephalitis, alcohol, drugs, and in old age, cerebrovascular accident, tumors, and other degenerative conditions. So if we know seizures according to the age group, it is easy to approach a person having seizures. Right. Now, how do we approach? What is the important history, examinations, and the investigations? History. History is going to be the most important component of clinical approach to a seizure patient. So history is the most important because examination and lab studies are often normal. The generalized seizures are usually due to CNS infection. So person comes with generalized seizures, should always think about metabolic abnormalities like hypoglycemia, hyponatremia, or drug intoxication, or alcohol withdrawal, or CNS infections. Suppose a person comes with focal seizures, we have to think of structural causes, and therefore we have to take CT or MRI. So focal seizures, we should always image the person because structural causes are very common. We take CT or MRI. Generalized seizures could be because of metabolic impairment, so we have to check out on the glucose, sodium, calcium status, or it could be infections. So we need to do CSF analysis. EEG. When we take EEG, the electrographic seizure activity, they will be abnormal, repetitive, recurrent, and the disease onset and termination will be clearly visible from the background. So they are abnormal, repetitive, and rhythmic. Not all persons who have clinical features suggestive of seizures are having definitely seizures. There are a lot of seizure mimics. So what are the differential diagnostic conditions of seizure? It could be syncope. When there's a decreased blood supply to the brain, they may fall. So we may mistake them to be having seizures. Syncope, psychogenic, attention-seeking behavior, especially women may be throwing psychogenic seizures. We call it as conversion disorder. The one good way to differentiate psychogenic from true seizures is to measure the serum prolactin levels. If the serum prolactin levels are increased within the 30 minutes of seizure onset, most of the generalized seizures and some of the focal seizures, the serum prolactin level increases within half an hour of the seizure onset. Then it could be metabolic like alcohol and its withdrawal, or it could be migraine like basilar migraine. Transient ischemic attack may mimic a seizure, or a sleep disorder like narcolepsy may mimic a seizure disorder. In children, breath holding spells may mimic a seizure disorder. Movement disorders like choreoacidosis may mimic a seizure disorders. So we should have a broad differential diagnosis for seizures and confirm whether it is a seizure or true seizure or not. Right. Before we embark on the treatment, we need to know the anti-epileptic drugs. Instead of going through all the anti-epileptic drugs and trying to remember and memorize it, if we know the basic mechanisms of anti-epileptic drugs, it becomes easier for us to remember and approach a person with seizure confidently. If we see the anti-epileptic drugs, the mechanisms of action, it falls into basically 7 groups. So almost all the anti-epileptic drug falls in these 7 groups. What are the 7 groups? One is the inhibition of sodium channel blockers, inhibition of sodium dependent action potentials in a frequency dependent manner. So basically they are sodium channel blockers like phenytoin and carbamazepine. Second is the inhibition of the T-type calcium channels in thalamic neurons. So in absence epilepsy they are very useful like sodium valproate and ethosuximide. The third is the facilitation of the opening of the potassium channels. So they let the potassium out, and the drug which comes under this category is ezogabine. Ezogabine is a potassium channel opener. And then we have drugs which attenuate glutamate activity. The seizure is the brain activity is basically under the control of 2 hormones, 2 chemical substances, 2 neurotransmitters. One glutamate, second is GABA. Glutamate is the neuroexcitatory substance, so it increases the propensity to develop seizures. GABA decreases the propensity to develop seizures. So seizures can be adequately controlled if we decrease glutamate level or increase the GABA level, gamma aminobutyric acid. So we have to decrease glutamate level. So we have good anti-epileptic drugs which decrease glutamate. So drugs which decrease the glutamate are the lamotrigine and felbamate. And we have drugs which potentiate the GABA receptor function, like benzodiazepines and barbiturates. And then we have the drugs which increase the availability of GABA, like valproate and gabapentin. And finally, we have drugs which modulate the release of the synaptic vesicles, like levetiracetam and brivaracetam. So basically, the mechanism of action of anti-epileptic drug falls into these 7 categories: sodium channel blockers, calcium channel blockers, drugs which increase glutamate, drugs which decrease glutamate, drugs which increase the GABA receptors, drugs which increase the GABA action, drugs which enhance the potassium release, facilitation of the opening of potassium channels, and finally drugs which modulate the release of the synaptic vesicles like levetiracetam and the brivaracetam. So having known the mechanism of the action of the anti-epileptic drugs, now let's see the principles of the anti-epileptic therapy, or the principles of the treatment of epilepsy. The first is the acute management of seizures. How are we going to manage the seizures in an acute manner? First is, we have to put the patient in a semi-prone manner so that patients don't aspirate. So put the persons in a semi-prone manner and turn the head to the side to avoid aspiration. So put the patient in a semi-prone manner, turn the head to the side to avoid aspiration. Second is the correction of metabolic factors like hypoglycemia, hyponatremia, hypocalcemia. So correct the sugar levels, sodium levels, calcium levels, and if a person is alcohol intoxication, we have to take care of the alcohol levels. Third, the person acute management of seizures includes the most dangerous component, the status epilepticus. So status epilepticus is recurrent seizures. Sometimes there can be seizures coming frequently without regaining of consciousness. This we call as status epilepticus, and it is emergency. It could be either generalized convulsive status epilepticus or non-convulsive status epilepticus. Convulsive status epilepticus is more dangerous because it has got effect on the cardiopulmonary function. Non-convulsive status epilepticus is not as dangerous as the convulsive status epilepticus. Usually we start initiating treatment after 5 minutes, because once 5 minutes or after 5 minutes, lot of chemical changes take place and it could be disastrous for the person. So we generally, the literature says 30 minutes or 20 minutes, most of them take 5 minutes as the criteria, and beyond 5 minutes, they start treating the person as suffering from status epilepticus. So what are the drugs we give? Initially, we give the lorazepam followed by phenytoin. If it is not getting controlled, then we go for midazolam. If it is still not getting controlled, then we go for the anesthetic drugs like pentobarbital. And then finally we go and give ketamine if it is refractory epilepsy. Here there is one important concept. The initial phase of the status epilepticus is because of the gamma aminobutyric acid, decreased level of the gamma aminobutyric acid. So we have to give drugs which enhance GABA levels. That's why we give diazepams, lorazepam. But towards the later phase of the status epilepticus, it is because of the increase in the glutamate levels, excitotoxic substances. So we give drugs like ketamines which act against the NMDA glutamate receptors. Very important. Initially we give GABA agonists, and towards the later part of the status epilepticus, if it is refractory, we give glutamate antagonists, NMDA glutamate antagonists like lamotrigine. Yeah, then finally, this is the acute management of status epilepticus. Then we go for the long-term therapy. So long-term therapy includes treatment of the underlying condition. Like tumor or CVA, we have to treat the underlying condition. Avoidance of precipitating factors like sleep deprivation, addressing the social and psychiatric factors. Lot of persons having seizures have psychiatric disturbances, and therefore we have to give drugs which which take care of their depression and enhance the antidepressive levels, make them less depressive. Antidepressants, if we give like tricyclic antidepressants, they have a tendency to cause or propend to cause seizures, exacerbate seizures, and therefore the preferred drug to treat depression with epilepsy is selective serotonin reuptake inhibitors, fluoxetine. So fluoxetine is the preferred antidepressive drugs used in persons with epilepsy and psychological or psychosocial issues. Then we give anti-epileptic drugs. Here we have to be careful because though monotherapy is the preferred way of treatment, sometimes we need to give many drugs, especially the best combination is sodium valproate and lamotrigine. When we give anti-epileptic drugs and perhaps other anti-epileptic drugs or other drugs for comorbid condition, one important principle we need to know. One are the drugs which are enzyme inducing drugs. Some anti-epileptic drugs are enzyme inducing drugs. And one drug, especially sodium valproate, is enzyme inhibiting drug. Why is this important? Drugs like phenytoin, carbamazepine are enzyme inducing drugs. So when they induce the hepatic enzymes, the clearance of other drugs becomes very fast and therefore they become ineffective, like oral contraceptive pills. So we have to be very careful when we give hepatic enzyme inducing drugs like phenytoin or carbamazepine. The other drugs get rapidly metabolized and therefore we need to take we have to take note of this. We either have to increase the dose of the other drugs which are given along with the hepatic enzyme inducing drugs. Second is the hepatic enzyme inhibiting drug like sodium valproate. Since it inhibits hepatic enzymes, drugs which act on this, they do not get metabolized fast and therefore they have long duration of action, and therefore we have to decrease the dose of other drugs when we give sodium valproate. The best synergistic combination for epilepsy is sodium valproate and lamotrigine. But then this principle is very, very important here. As I said, sodium valproate is a hepatic enzyme inhibiting drug, and therefore if we give the normal lamotrigine dose, it acts for a long time and it does not get metabolized easily. So when we give lamotrigine with sodium valproate, we have to decrease the level of lamotrigine. Otherwise, sodium valproate, which inhibits the hepatic enzymes, will not allow the lamotrigine to get metabolized, and therefore its duration of action will be prolonged, and therefore we have to decrease the dose of lamotrigine when we give lamotrigine with sodium valproate. This principle is very important and essential because lamotrigine and sodium valproate is the best synergistic combination to treat epileptic conditions. As I said earlier, the sodium valproate is a good anti-epileptic drug. It can be used for focal seizures, it can be used for generalized seizures, it can be used for typical absence seizures, atypical absence seizures, atonic seizures, myoclonic seizures. Wonderful drug, sodium valproate, a broad spectrum anti-epileptic drug. But one problem with the sodium valproate is that it is a teratogenic drug, and therefore when we should not give this drug, anti-epileptic drug, sodium valproate, in pregnant women because it can cause neural tube defects. If at all we need to continue sodium valproate drug, we have to give it in a very low dose and supplemented by folate. As far as possible, sodium valproate should be avoided in pregnant women with epilepsy. One of very good anti-epileptic drugs in pregnancy is levetiracetam. Though we give anti-epileptic drugs, not all epileptic conditions are equally susceptible to control. For example, Measle temporal lobe epilepsy syndrome, it may not respond to anti-epileptic drugs, and therefore we have to do surgery. So these are all the long-term treatment for epilepsy. When we give anti-epileptic drugs, as I said, monotherapy is the goal. As far as possible, we have to give single anti-epileptic drug. But in case if the single anti-epileptic drug is not able to control the seizures, then we can add the second anti-epileptic drug, slowly increase it, and once the seizures are under control, the first anti-epileptic drug may be slowly tapered over a few months. But monotherapy is the goal for epilepsy. Some forms of epileptic disorders like Measle temporal lobe epilepsy syndrome may not respond to anti-epileptic drug, so we sometimes do surgery, And some of the epileptic conditions which just do not get control with anti-epileptic therapy, we have to go for other forms of therapy like vagus nerve stimulation or ketogenic diet. So these are all the important, indispensable concepts of seizure, fits, epilepsy. One has to know all these important, indispensable concepts of epilepsy. Hope you have enjoyed listening to my lecture. If you have any suggestions or comments, kindly post onto my YouTube channel. But please like and subscribe my YouTube channel, Dr. Sreenivas Medical Concepts, and my FB page, Dr. Sreenivas Concepts. Thank you. Bye.